So I think you can have the skills and the masterly surgical skills of my co-instructors, and you'll win the battle. But to win the war, you have to know how to rehabilitate, do amblyopia management, deal with strabismus, and also predict the myopic shift. So basically, all congenital cataracts, we know that they're rare, but at the same time, these are very important situations because this is like an artwork that you're going to do and put in your drawing room for the rest of your life, because the patient's going to keep coming to you for the next 60, 70, 80 years. So you have to get it perfect from day one. So we have always remember, you may be the best surgeon, like sir said. You may want to put the lens in the bag, but later on you may have the capture, you may have, and you, if you don't rehabilitate, you may not have visual success altogether. So what we want to talk about is the key post-op concerns, which is amblyopia, strabismus, refractive changes like myopic shift, and parental compliance and follow-up, because without that, the child will not be able to get his vision completely back. So what we're talking about first is the amblyopia management. We need to go ahead and do an early intervention, which is a cornerstone for any sort of visual rehabilitation, as early as possible. The prevalence is because it matters. Amblyopia is the most common cause of poor visual outcomes after pediatric cataract surgery. Incidence of as high as 74%, especially in unilateral cataract cases. And it's a very sensitive period of visual development, and with cataracts, it's already taken a back seat. So once you've done this with the surgery, get right into it. And we have enough literature to say that as early as possible, and patching is often the first and the only therapy that we start with. The variety of patching goes along with your various studies, which is mild, it should be at least 2 hours, moderate goes up to 4 hours, and severe about 6 hours. And unilateral cataract, you'll be even more aggressive when you do it. And we also have options of dioptic therapy, getting binocular vision, playing with the iPads. Everything is coming into play, and I think these are good situations to use them whenever you can. Now, atropine penalization for non-compliant kids, we know we've used 1% atropine for in the pediatric study, and it actually gives equal results to patching, and it's something that we can all explore, especially post-op. Atropine also helps. So compliance and monitoring, this is, I believe, is very, very important slide. That is, parental education is key. You need to keep talking to the parents. They are your patients as well. You have to keep talking to them how important it is to bring them on the same page when we are fighting post-op, because most of them don't realize, they feel the surgery is done, the job is done, the child will get vision. But actually, it's just the first part of the battle. Optical rehabilitation, we have aphakic corrections and pseudophakic corrections depending on the situation. Aphakic, we use contact lenses, and that gives great results even in long term. We have ITS to vouch for that. We also have spectacles for bilateral aphakia in older children. It can be used in interim, and later on when the child grows up, you can do your secondary IOL implantation. When you implant the IOL in the first go, we have options that we predict the child's myopic shift by leaving a little hyperopic. I prefer to do the rule of 7, which is by 7 years of age I could correct for emmetropia, and less than that I minus the age and do the hyperopic correction. We also have this is the rule of 7. And we also have to, like sir said, the real is the mnemonic, where you have to regular follow-up, and every time you have to look for different things that can go wrong. So myopic shift, why is it important? Because if you don't do so, the child will be very myopic. We know about minus 4.3 plus minus 3.25. Look how big the variation is, that the child will become more myopic as time goes. We have done a lot of study on trying to get it right. We're still working on it. I and Dr. Jitani have got our data together, and we talk about low dose atropine in these post implanted pseudophakic eyes, and we say that it has 30 to 40% real reduction in axial length growth over 2 years that we have data for. Strabismus management, of course, the most important part, because often these cataracts are not alone, they also come with strabismus, and that can be equally important to correct. So we have various risk factors, various syndromes, where you have Sir showed a beautiful video of a child with nystagmus, and trying to see even beyond that along with the strabismus. There's a lot of literature which talks about how factors associated with strabismus actually cause a lot of amblyopia, post congenital cataracts, even post the surgical procedure. And incidence is as high as 27%, which, if not now, later on they develop. And this is one of the data that we collected from our literature, and we compared it to how it was. So points from our study was that age is a very important factor. follow-up is very, very important, and often if you don't correct the amblyopia in time, they can actually end up with strabismus, and that needs to be corrected as well. So management options again are refractive, amblyopia therapy, binocular rehabilitation, and that doesn't work, orthoptics, and then later on strabismus. We have a lot of questions which are unanswered. Is that should we go ahead with emetropia in these cases, or should we actually go near emetropia? Use of any advanced IOLs, that is something that we are still very, very cautious about. And how do we do the amblyopia therapy? So this is a case that I would like to show, which is about 7-month-old child with unilateral cataract. We did a case, and after successful surgery, 1 month, you noticed that the child had a bit of a strabismus. So you can see that happening. Can you see that large exotropia? And follow up in 8 months after, we actually noticed that the child was corrected to emetrop after doing a good cataract surgery and rehabilitating. So no requirement for any sort of intervention surgically. There's another case with 2-year-old where we did a lens aspiration and implanted IOL, and of course this was how the child was after a few years of loss to follow-up, and we ended up needing a strabismus correction. In interest of time, I may not show the whole video, or maybe I can just skip. So post-op follow-up is basically the child does well. Thank you so much for your early morning attendance and giving us time and being here for a very important topic, and I hope we were able to share some important points with you. Thank you so much.
We have 1 minute.
We can take a question, or we can do chai pe charcha after this. Okay. Yeah. Exact time for implantation. Secondary or primary, sir? So generally, we are implanting IOLs in any child above 6 months of age, depending on the white to white and the axial length. If we are doing a secondary implantation, like in a traumatic cataract, depending on the choice of secondary IOL, if it's an SFIOL or iris claw, we do it at a later stage. If you have the bag, then of course in the bag implantation is the best, as early as possible.
And what is about bifocal glasses?
With bifocal spectacles?
Yes, glasses.
Glasses, yes. So we correct as early as possible. In a young child, you don't need to give bifocals. You just correct them for near and give them unifocal glasses. As the child grows up, we do pupil bisecting bifocals in many situations, just to see the child is using the near as well.
So normally around 4, a child can use bifocals. Before then, we correct them for near. Okay.